Imagine a patient walks into your consultation room. They are complaining of stomach ache, maybe feeling a bit weak, and, well, they're just asking for a glass of water.
Yeah, they're fully awake. They're talking to you.
Exactly. And yet their body is in the middle of a catastrophic, potentially fatal metabolic collapse.
It is terrifying how normal they can look at first glance.
Right. So today we are tracking exactly how a conscious patient hides a lethal case of diabetic ketoacidosis, or DKA. If you are a medical student listening right now, preparing to step onto the wards and, take on real patient responsibility, well, this is your clinical walkthrough.
We are going step by step.
Yeah, we're tracking a patient from the moment they walk through those doors to the exact moment they are medically cleared.
And we really need to set the stakes immediately here, because that walking, talking presentation, it breeds complacency. And DKA is a massive medical emergency.
Yeah, I mean, how fatal are we talking?
Well, if you're practicing in the UK, the mortality rate is actually relatively low. It hovers around 2%.
Okay, 2%.
Right. But outside of a hospital setting or in developing nations, it remains highly fatal. And the drivers of that mortality, they tell us a lot about the systemic stress DKA causes on the body.
Like what specifically?
So in children and adolescents, the leading cause of death is actually cerebral edema. The brain literally swells.
Wow.
Yeah. And in adults, the mortality drivers shift to these huge systemic failures. So severe hypokalemia, acute respiratory distress syndrome, or even secondary complications like a massive myocardial infarction or sepsis.
So it's basically a total system failure. And, the traditional terminology really does us a disservice here. You still hear diabetic coma used as a shorthand all the time.
Oh, absolutely. And it's so misleading.
It really is, because it trains clinicians to wait for an unconscious patient before hitting the panic button. But our source material makes it incredibly clear an actual coma only happens in about 10% of DKA cases.
Exactly, just 10%.
Which is why the medical community shifted to the term diabetic ketoacidosis in the first place, specifically to break that mental association.
Right, because if we can't rely on them being unconscious, we have to have other tripwires.
Exactly. So the patient is sitting right in front of you. What is the very first physical clue giving away that this metabolic storm is happening inside?
Well, you are looking for a constellation of really profound dehydration and systemic starvation. The patient will report polyuria, excessive thirst, and usually some recent weight loss.
And they mentioned feeling weak, right?
Yeah, severe weakness, nausea, and vomiting are super common. They also often mention leg cramps and blurred vision.
I've heard abdominal pain is a big one too, right?
Yes, especially in children. Abdominal pain is notoriously common in kids with DKA, and it can actually mimic an acute abdomen.
Oh, wow. So you might think it's appendicitis or something?
Exactly. And on physical exam, the loss of fluid volume is just obvious. You will see a loss of skin turgor, a furred tongue, cracked lips, and even reduced intraocular pressure.
Because they're just that dry.
Right. They're often hypotensive, tachycardic, and their body is literally pulling blood away from the periphery to protect the organs.
Which gives them cold extremities, right? And peripheral cyanosis.
Precisely.
Okay, so beyond the visual, there are two specific sensory clues to watch out for. The first is visual and auditory, which is Kussmaul breathing.
Ah, yes. Kussmaul breathing.
It's this very deep, sighing respiratory pattern. And, they aren't just out of breath. Their respiratory center is actively detecting profound metabolic acidosis.
It's a panic response from the brainstem.
Right. It's desperately trying to compensate by blowing off massive amounts of carbon dioxide to try and raise the blood pH.
And the second sensory clue.
It's olfactory. You are smelling their breath for acetone, which has this very distinct, sickly, sweet, kind of fetid odor.
Yeah, it smells like nail polish remover. And the moment you see that deep air hunger and smell those ketones, you initiate the 0-hour immediate investigations.
The clock starts.
Right. You need venous blood for urea, electrolytes, glucose, bicarbonate, and acid-base status.
And notice I specified venous blood.
Yeah. Why venous and not arterial? Because you do not want to waste time or cause the patient the sheer agony of an arterial blood gas draw. Venous blood is perfectly sufficient for portable analyzers, and the pH difference between venous and arterial blood in DKA is, honestly, clinically negligible.
That's a great tip for the wards.
Yeah, it saves so much time. You also need a urine or blood assay for ketones, an immediate ECG, and a full infection screen.
So that's blood cultures, urine cultures, C-reactive protein, and a chest x-ray.
Exactly.
Okay, but looking at that standard infection screen, I mean, if that full blood count comes back showing marked leukocytosis, like a white blood cell count just through the roof, the immediate assumption on the ward might be that an underlying infection triggered the DKA.
Oh, yeah, but that's a massive pitfall.
A dangerous one.
Right,
Okay.
very dangerous. Leukocytosis invariably occurs in DKA purely as a physiological stress response.
Wait, really? Just from stress?
Yes. The massive catecholamine surge causes white blood cells to demarginate from the blood vessel walls and just flood the circulation.
Oh, wow.
So, while an infection is absolutely a common trigger for DKA, a high white count alone does not confirm one. You must rely on your cultures and your CRP to identify a genuine infectious trigger.
Okay, so while those lab results are processing, let's look at the actual biochemical cascade tearing this patient apart, because our entire treatment protocol targets this exact mechanism.
Right, the underlying pathophysiology.
Yeah, the standard analogy is usually a city losing its power grid, but, well, I think a supply chain crisis is far more accurate here.
Oh, so?
Imagine the cells are a massive network of manufacturing plants, and glucose is the raw cargo they need to function. The cargo is piling up outside on the loading docks, that's the blood, but the loading dock doors are locked tight.
And insulin is the key to those doors.
Exactly. Without insulin, the cells are literally starving to death while drowning in a sea of glucose.
And, when a cellular factory starves, it takes drastic measures to survive. It sends out emergency signals, stress hormones like cortisol, glucagon, and catecholamines.
Total panic mode.
Total panic. So the body begins unrestrained lipolysis. It just starts ripping apart its own structural fat stores for alternative energy.
And that's where the liver steps in.
Right. The liver takes those free fatty acids and rapidly converts them into ketones. Now, ketones can act as an emergency fuel source, but they are highly acidic.
Hence the ketoacidosis.
Exactly. The production rate wildly exceeds the body's metabolic capacity to clear them, and the blood turns increasingly toxic.
Which brings us to the diagnostic triad of DKA. We are looking for 3 concurrent biochemical failures here.
What's number 1?
Number 1, hyperketonemia. So blood ketones at or above 3.0 millimoles per liter, or severe ketonuria on a dipstick.
Right. And number 2?
Number 2, hyperglycemia, blood glucose at or above 11 millimoles per liter. And finally, number 3, metabolic acidosis. So a venous bicarbonate dropping below 15 millimoles per liter, or a venous pH below 7.3.
That triad is key. It explains the acid and the sugar, but we really have to address that profound dehydration you brought up earlier.
Yeah, how exactly does the sugar cause the dehydration?
Well, the hyperglycemia directly drives the fluid loss through osmotic diuresis. See, the kidneys have a transport maximum for glucose. Once blood sugar gets high enough, the renal tubules simply cannot reabsorb it all.
It just overflows.
Right. The excess glucose spills into the urine, creating this massive osmotic gradient that essentially drags water, sodium, and potassium
Right.
out of the body. An adult in moderate DKA is losing liters of fluid.
Liters. That is insane. And the source of that fluid loss shifts as the crisis deepens, right?
It does, yes.
Because early on, about half of the water loss comes directly out of the intracellular compartment. The cells themselves shrink, which is actually relatively asymptomatic at first.
Yes, the body hides it well initially.
But later, the fluid is pulled from the extracellular space, and that is when you see the drastic contraction of blood volume, the plunging blood pressure, and the renal ischemia.
Which culminates in oliguria, where the kidneys just shut down completely to preserve whatever tiny bit of volume is left.
It's a complete cascade. But before we move to treatment, we have to note a critical caveat about that diagnostic triad we mentioned.
Oh, this is vital for the wards.
Yeah, the severity of the blood glucose level does not reliably dictate the severity of the acidosis.
Not at all.
You will encounter euglycemic DKA, particularly in type 1 diabetics who are pregnant, where the acidosis is completely life-threatening, but the blood sugar is surprisingly moderate.
Yes, and conversely, you might see massive hyperglycemia with minimal ketones or acidosis.
Right, which points you toward hyperosmolar, hyperglycemic state, or HHS.
Exactly. The golden rule is never let a moderate glucose reading blind you to a crashing pH.
Okay, so the lab results are in. We have confirmed severe DKA. The clock officially starts for the 0 to 60-minute resuscitation window.
The golden hour?
We have a list of triggers that mandate immediate high-dependency unit admission or senior review. But, they aren't just random numbers. We are looking for signs that the body's compensatory mechanisms have entirely failed.
Right, so if the venous pH is below 7.0 or the bicarbonate is under 5, their buffering capacity is wiped out.
It's gone. What about potassium?
If admission potassium is already under 3.5, their total body deficit is catastrophic. And if their Glasgow Coma scale is under 12, the cerebral edema is already starting.
You also need senior review if oxygen saturation is below 92% on air, if systolic blood pressure is under 90, or if the heart rate is wildly tachycardic or bradycardic.
Or if the anion gap exceeds 16, if any of those are flagged, you escalate immediately.
Call for help.
Absolutely. But simultaneously, you initiate the primary protocol. You establish large bore IV access. If their systolic blood pressure is over 90, run 1 liter of 0.9% sodium chloride over 60 minutes.
And if the systolic is under 90?
Then they are in shock. You push 500 milliliters fast, like over 10 to 15 minutes, reassess, and get an attending physician in the room immediately.
Got it. And alongside the fluid, we start the fixed-rate intravenous insulin infusion. The standard is 50 units of human-soluble insulin in 50 milliliters of normal saline, running at 0.1 units per kilogram of body weight per hour.
Yes. And importantly, if the patient uses a long-acting subcutaneous basal insulin at home, you do not stop it.
Keep the basal going.
Always keep that basal dose going.
Right.
The background insulin is absolutely essential for the transition later on.
Right. But as this first hour unfolds, you are stepping right into the most dangerous phase of the initial resuscitation, which is the potassium paradox.
This trips up so many medical students.
It's where medical physiology gets incredibly deceptive. The initial lab results come back, and the patient's plasma potassium levels look elevated, or at least normal.
All right.
Yet the protocol assumes every single DKA patient has a massive total body potassium deficit. How can the blood be swimming with potassium if the body is completely depleted?
Because, well, the potassium's in the wrong place.
Okay, what do I mean?
The extreme metabolic acidosis creates a massive concentration of hydrogen ions in the blood. To buffer that acid, the body literally forces hydrogen ions inside the cells.
Right, that makes sense.
But to maintain electrical neutrality across the cell membrane, the cell has to kick something positive out. So it kicks potassium out into the extracellular fluid and the blood.
Wow, so it's just a swap.
Exactly. That intracellular shift, combined with the severe dehydration that's concentrated blood volume anyway, creates a deadly illusion of normal or high potassium.
But the reality is that the osmotic diuresis has been flushing potassium out through the kidneys for days. Plus, the dropping blood pressure triggered secondary hyperaldosteronism, forcing the kidneys to dump even more potassium.
Yes, their total cellular potassium is utterly drained.
So when we start aggressively pushing IV fluids and IV insulin...
We are about to pull the rug out from under that plasma potassium level.
Yeah, that sounds bad.
The moment the fluids dilute the blood and the insulin forcibly drives glucose and potassium with it back inside the cells, the plasma potassium plummets.
And if you haven't anticipated this...
The sudden severe hypokalemia will trigger a fatal cardiac arrhythmia.
Wow. So surviving that first hour means carefully monitoring that potassium shift while the initial liter of fluid restores circulating volume.
Exactly.
Now we move into the delicate balancing act, hours 1 through 24. We have to meticulously titrate the patient back to normal without swinging the pendulum too far in the opposite direction.
Right, so the fluid schedule steps down systematically. Pushing fluids too fast once intravascular volume is restored risks fluid overloading the lungs or exacerbating brain swelling.
So how does the step down work?
After that first rapid liter, you give the next liter of normal saline over 2 hours, the third liter over another 2 hours, the fourth over 4 hours, the fifth over 4 hours, and the sixth liter over 6 hours.
2, 2, 4, 4, 6.
Yep, and you must slow this rate further for children, the elderly pregnant patients, or anyone with heart or kidney failure.
And what about sodium?
Keep an eye on it. If plasma sodium exceeds 155 millimoles per liter, switch to 0.45% saline.
Okay, so as we monitor their capillary blood glucose hourly, we hit a fascinating pivot point. When the blood glucose drops below 14 millimoles per liter, which is around 252 milligrams per deciliter, the protocol dictates that we add a 10% glucose infusion at 125 milliliters per hour, running right alongside the saline.
Yes, we do.
I mean, we are actively infusing sugar into a patient admitted for toxic hyperglycemia. That sounds crazy.
It sounds completely backwards, doesn't it?
It does, but the logic here is that clearing ketones takes much longer than clearing blood glucose. If we shut off the insulin just because the blood sugar looks better, the locked warehouse doors slam shut again and lipolysis instantly resumes.
Precisely. The primary therapeutic goal of DKA treatment is stopping ketogenesis, and insulin is the only way to do that.
So the glucose is just cover fire.
Basically, the 10% glucose infusion provides a steady supply of cargo for the cells, allowing you to keep that continuous insulin infusion running at full strength. It clears the ketones without driving the patient into life-threatening iatrogenic hypoglycemia.
Amazing. Now, to manage the potassium plummet we discussed earlier, the replacement rules are strict. You add 40 millimoles of potassium chloride to the fluid bag only if the plasma potassium is between 3.5 and 5.5, and you must confirm the patient is actively passing urine.
That last part is crucial. If the kidneys are failing, you'll cause hyperkalemia.
Right. And if the potassium drops below 3.5,
Then the standard infusion isn't enough. You stop and escalate for central line replacement.
and if it's over 5.5,
You withhold it completely.
got it. Now, I know the temptation when faced with a profoundly acidotic patient is to try and chemically neutralize the acid.
Oh yes, the bicarbonate trap.
It feels incredibly counterintuitive not to. Like, if the venous pH is 6.9, why not just push intravenous bicarbonate and fix the number immediately?
Because treating the number ignores the physiology. Intravenous bicarbonate therapy is strictly contraindicated.
You ever use it?
Never. The acidosis, while dangerous, actually forces the oxygen dissociation curve to the right, which improves oxygen delivery to starving tissues.
Oh, it's adaptive.
Yes. If you artificially spike the blood pH with bicarbonate, peripheral chemoreceptors sense the normalization and slow the patient's respiratory rate. They stop Kussmaul breathing.
And then carbon dioxide starts building up in the blood.
Exactly.
And carbon dioxide crosses the blood-brain barrier far faster than bicarbonate does.
Which is the disaster. The CO2 floods the brain, mixing with water to form carbonic acid. So while the blood pH looks better, you have induced a paradoxical, profound cerebrospinal fluid acidosis.
So the brain becomes highly acidic.
Yes, which is a direct mechanism for catastrophic cerebral edema, particularly in young patients. Adequate fluid and insulin replacement will resolve the systemic acidosis naturally and safely.
That is wild.
It is. And on the topic of unnecessary additives, there is no clinical evidence supporting routine phosphate replacement either, unless you observe severe respiratory or skeletal muscle weakness linked to low levels.
Okay, so we have to land this plane slowly. What are the specific biochemical targets we are aiming for during the step-down phase?
We want to control descent. Blood glucose should fall by 3 to 6 millimoles per liter per hour. Alternatively, blood ketones should fall by at least 0.5 millimoles per liter per hour.
And if you drop it too fast?
If you drop the glucose faster than that, you radically alter the osmotic pressure in the blood. The blood becomes hypotonic compared to the brain tissue, and water rapidly shifts into the central nervous system.
Cerebral edema again?
Again, you must avoid sudden osmotic shifts.
Okay, so we are reaching the 12 to 24-hour mark. The acidosis is clearing, the alarms have stopped. But transitioning a patient off an IV insulin drip is a high-risk handover. How do we define actual resolution, and how do we safely pull the lines?
So DKA is biochemically resolved when blood ketones fall below 0.3 millimoles per liter, and the venous bicarbonate rises above 18 millimoles per liter.
Okay, 0.3 and 18.
Right. At that point, assuming the patient is fully awake, eating and drinking normally, you can transition back to a subcutaneous insulin regimen.
But there is a massive trap here with the timing. You cannot just switch off the IV pump and give them a shot.
No, you absolutely cannot.
Because the half-life of intravenous insulin is only a few minutes? Subcutaneous short-acting insulin takes 30 to 60 minutes to absorb and peak.
Right.
If you disconnect the IV at the exact moment you give the injection, the patient spends half an hour with absolutely zero insulin in their system. The warehouse doors lock again, and they rebound straight back into ketoacidosis.
It happens all the time. You must keep the IV insulin running for exactly 30 minutes after the subcutaneous injection is administered.
That overlap is non-negotiable, and it is exactly why we kept their long-acting basal insulin running from the very beginning of the admission.
Exactly. It ensures there's a steady baseline of insulin coverage during this vulnerable transition.
Beautiful. So once they are medically stable, the clinical responsibility shifts from acute resuscitation to etiology. Like, why did this happen?
Right, finding the root cause.
We know DKA is a hallmark presentation for undiagnosed type 1 diabetics. We know an acute infection can spike insulin demand and trigger a crisis in established patients. But recurrent DKA in young, known diabetics requires looking beyond the biochemistry.
It really does. In young patients with recurrent episodes, you must assess their psychosocial environment. Up to 20% of these recurrent cases are linked to psychological distress.
Say eating disorders.
Yes, eating disorders, or even intentional insulin omission to lose weight. Reviewing their injection technique, identifying social stressors, and providing psychological support is just as critical as the fluid resuscitation.
Because if you ignore the behavioral trigger.
They will be back in your trauma bay within a month.
Wow. Well, that brings us to a really fascinating demographic shift to think about as we wrap up. Historically, we associate DKA almost exclusively with the absolute insulin deficiency of type 1 diabetes.
That's the classic teaching.
Right. But our sources highlight a rising trend of DKA presentations in patients who actually have underlying type 2 diabetes, which is particularly prevalent in Black and non-Hispanic populations.
Which is strange, structurally speaking.
It is, because type 2 diabetes is fundamentally defined by insulin resistance. The insulin is there, but the cellular doors are rusted and won't open easily.
It creates a profound contradiction in how we classify the pathology.
It really does. I mean, if type 2 patients are crashing into a state of absolute metabolic failure mimicking type 1, the rigid lines we draw between these diseases are blurring.
Completely blurring.
What does this mean for the future of diabetic classification? Are there transient states of absolute beta cell failure in type 2 patients that we just don't fully understand yet?
It's a huge question for the next generation of doctors.
I leave you to ponder that as you head onto the wards. Remember, the next time a patient walks into your consulting room complaining of a stomach ache and thirst, look past their consciousness. Watch for the air hunger, smell the acetone, and catch the metabolic crash before the power grid completely collapses.